2P is acute appendicitis appendectomy or the antibiotic first strategy. Definition. Appendicitis is an inflammation in the appendix of finger shaft, a site projecting from the colon on the lower right side of the abdomen.
Puede ser yo el mismo.
The appendix is the little one-ended tube that is attached to the cecum of the large intestine. Sometimes it's called the vermiform appendix, where vermiform means worm-shaped, so that should paint a pretty clear picture of what it looks like. And this odd, kind of cute little worm-like structure's function is actually unknown, though some theories suggest that it might be a safe house for gut flora, and some evidence seems to suggest that it plays a part in the lymphatic and immune system. Other, arguably more cynical viewpoints think that it's just a useless vestigial organ from our ancestors. Whatever the case may be, the fact remains that it's pretty talented at getting inflamed and causing abdominal pain, a condition known as appendicitis. As much as 10% of the population develops appendicitis at some point, and it's the most common surgical emergency of the abdomen. Since the appendix is a hollow tube, the most common cause of inflammation is something getting stuck in or obstructing that tube, like a fecalith, which is a hardened lump of fecal matter that finds its way into the lumen of the appendix and wedges itself there. It can also be other things though, like seeds that weren't digested or even pinworm infections, which are intestinal parasites. Another cause of the obstruction, especially in children and adolescents, is lymphoid follicle growth, also known as lymphoid hyperplasia. Lymphoid follicles are dense collections of lymphocytes that get to their maximum size in the appendix during adolescence. Sometimes this growth, though, can literally obstruct the tube. Also, when exposed to viral infections like adenovirus, measles, or even immunizations, the immune system ramps up and these follicles can grow as well. Whatever the cause of the obstruction is, now the appendix is plugged up, right? Well, the intestinal lumen, including the appendix, is always secreting mucus and fluids from its mucosa to keep pathogens from entering the bloodstream and also keep the tissue moist. Even when it's plugged, the appendix just keeps secreting as usual. When this happens, fluid and mucus builds up, which increases the pressure in the appendix. Just like when you fill up a water balloon, it gets bigger and physically pushes on the afferent visceral nerve fibers nearby, causing abdominal pain. Along with that, the flora and bacteria in the gut are now trapped, right? And intestinal bacteria that are usually kept in check in the gut, like E. coli and Bacteroides fragilis, are now free to multiply. And this causes the immune system to call up white blood cells, and pus starts to accumulate in the appendix. This activation of the immune system can be seen in the lab as an increase in the serum white blood cell count. Patients might also develop a fever in response to the infection, which in combination with right lower quadrant abdominal pain, at the point roughly where the appendix is, known as the McBurney's point, is a super important sign for identifying appendicitis. Also, along with the fever, other classic symptoms include nausea and vomiting. Now, if that obstruction persists, the pressure in the appendix increases even more. At a certain point, as the pressure keeps going and it continues to swell up, it pushes and compresses the small blood vessels that supply the appendix with blood and oxygen. Without oxygen, the cells in the walls of the appendix become ischemic and eventually die. Since these cells were responsible for secreting mucus and keeping bacteria out, now the growing colony of bacteria can invade the wall of the appendix. As more cells die, the appendiceal wall becomes weaker and weaker, and for a small proportion of patients, it gets weaker to the point where the appendix ruptures. Rupture of an infected appendix allows the bacteria to escape the appendix and get into the peritoneum. And patients often experience peritonitis with rebound tenderness, meaning pain when pressure is taken off, again around the McBurney's point. Patients might also have some abdominal guarding, where the abdominal muscles tense up when pressed to try and avoid pain. The most common complication with the ruptured appendix is pus and fluid getting out and forming an abscess around the appendix, called a paraappendiceal abscess. Sometimes subphrenic abscesses might also form, and these would be tiny abscesses below the diaphragm but above the liver or the spleen. The standard treatment for appendicitis is appendectomy, which is a surgical removal of the appendix along with antibiotics. If patients have abscesses, these are also important to surgically drain. Removing the appendix isn't known to have any negative side effects, and sometimes it's removed if the surgeons are already doing an abdominal surgery for some other reason, just to avoid an appendicitis down the road.
Application in nursing. Control of vital signs, placement of a peripheral venous catheter, extraction of blood for analysis, complete blood count, check for possible leukocytosis, electrolytes, and hematimeter, introduction of nasogastric tube, and possible start the aspiration by medical order. Positioning the patient in the Fowler position to reduce pain and have the correct sex. Possible comfort.
Removal of the appendix, called appendectomy, is performed when appendicitis is suspected. Right lower abdominal pain, fever, and elevated white blood cell count are common symptoms and signs of appendicitis, which usually occurs when a blockage develops between the appendix and the intestine. This leads to infections, swelling, and distension. If the appendix is not removed, it can lead to a life-threatening perforation or rupture. The most common treatment for appendicitis is appendectomy, which is almost always performed on an emergency basis. Laparoscopic techniques require only tiny keyhole incisions or puncture wounds. To get inside your abdomen, your surgeon will make a small keyhole incision near your belly button, known as an umbilical port, with a tube called a trocar. Gas will then be pumped through this port to puff up your abdomen so its contents can be viewed more easily. Next, your surgeon will insert a laparoscope through this port. The laparoscope is a thin tube with a tiny camera on the end of it that projects images onto a monitor to guide your surgeon's work. Using the laparoscope, your surgeon will examine images of your appendix on the monitor to confirm that it's red and swollen. If your appendix needs to be removed, additional ports will be created. Your surgeon will pass surgical instruments through these other ports to grasp the appendix. Another instrument will be used to separate the appendix from the intestine and close the appendix will be placed into a specimen bag and removed through one of the ports. At the end of the procedure, the laparoscope and surgical instruments will be removed. A port valve will be left in place briefly to allow the gas to escape from the abdomen. The incisions will be closed with sutures, followed by skin glue or skin closure tape. If your appendix can't be removed laparoscopically, your surgeon will switch to an open procedure. Reasons for switching to an open procedure include an extensive infection or abscess, a perforated appendix, which means there's a hole in it, obesity, dense scar tissue from previous abdominal surgery, difficulty viewing the organs with the laparoscope, and bleeding problems during the operation. An open appendectomy is done directly through a slightly larger abdominal incision over your appendix, or through a lower midline incision as needed. The surgeon will tie off the appendix with sutures and remove it. Then the incision will be closed with sutures or staples.
Pros and cons. Complications are more frequent the later the diagnosis and definitive treatment. Infection of the surgical wound, intra-abdominal access, intestinal obstruction, and the appearance of septochondral fistulas are the most common, although they do not affect 5% of all appendectomies. Conclusion. Appendectomy consists of the extraction of the second appendix through a small incision in the lower right region of the abdomen after a generally complicated procedure. The person can act in next 24 to 36 hours and return to daily activities in less than 2 weeks.